Hi, everybody. Thanks for joining me on this talk on managing patients with indolent B-cell malignancies on BTKis. My name is Dominique Duquette. I'm a pharmacist in Quebec City, and it's an honor for me to give this talk because it's following a paper that we published in Current Oncology. So it gives another life to that article. So the objectives today are to talk about BTKis and to see the difference between the three that are available on the market, gain knowledge on dosing, co-administration considerations, and adverse event management, because there are some that pharmacists need to take care of. Now, the rationale for this was because we are now getting more BTKs that were available. We were used to one, but there are some difference that we need to understand between the three that are available right now. And it's a crucial part to nurse and pharmacists to manage these patients. So the point of this was to give better knowledge of the differences between the three and how to manage them. And this was done in a Current Oncology where a nurse and I were involved in bringing this paper. Also, a doctor was with us. So there's more information on that paper, so you can refer to that. It's in Current Oncology. It's in open access. So please feel free to go to that to have more information on this topic. So we have a couple of things to go over. So I'm going to go over more quickly for this presentation, but again, it's all in the paper that you can refer to. So as a background, well, BTKis are being used in multiple diseases that are involved with B cells, so in non-Hodgkin lymphoma and CLL. So they've been around for a while with ibrutinib, but now we have acalabrutinib and zanubrutinib that are available. So there are some unique things about these three drugs. It's not everything's the same, so we need to better understand. So this is the mechanism of action. So the BCR pathway, where when SYK is activated, it's gonna bring BTK, BLNK, and PLC gamma 2. And our drugs are acting on the BTK. So in 2014 was when first BTK was Canada approved, and it was ibrutinib. Since then, there's been multiple indications for ibrutinib. There are side effects to ibrutinib, and that's why the second generation BTKis tried to have a more selective profile, which would have less side effects. That was the plan. So we'll see how this is the actual case or not. So acalabrutinib was first approved in 2019, and zanubrutinib was first approved in 2021. So about the selectivity. So the blue part is the part that you want the action on the BTK, and the red parts are off targets and would be associated with side effects. So there are the three drugs, and we have ACP 5862, which is the active metabolite of acalabrutinib, and it has a lot of red on it, which might be responsible for the side effects of the acalabrutinib because it's off targets. So this is really good to explain in theory, but we're going to dive more in the studies to see how that translates in real life. So there was a Health Canada warning about ibrutinib, and some of the guidelines were changed because of that, warning about fatal sudden cardiac events. NCCN did bring down ibrutinib from preferred to other recommended regimen, and a few other guidelines that are available did do the same. So we are now, for a new patient, moving towards the second generation BTKis. So here is a timeline where you see the different indications of ibrutinib. On top, you see acalabrutinib and zanubrutinib, which are newer, and they don't have all the same approvals, as you can see here. So ibrutinib and zanubrutinib have more indications than acalabrutinib, but you can refer to that to know if you can use a certain drug or not with the indications. Now, again, provincial funding is different from province to province. So it's another thing you need to look at is in your province, what is reimbursed and for which indications. Now, about pharmacokinetics and dosing. So ibrutinib is in 140 milligram capsules. You take 3 a day at once a day. For MCL and MZL, it's 4 capsules a day. For acalabrutinib, it's 100 milligram capsules, so it's 1 capsule twice daily. And for zanubrutinib, there are 2 dosing that you can try. So it's 80 milligrams per capsule. So you need to give either 2 capsules twice a day or 4 capsules once a day. And we're going to dive in that a little bit. Well, just right now. So this is a schema of how the level of free drug can are in the patient with time, and you can see the green bars are the IC50 levels. So they're not the same for each molecule. So zanubrutinib is quite lower than the 2 others. And what you can see is how the drug is higher or not than that level. So for zanubrutinib, you can see that it stays higher, either in once daily or twice daily, all the time from the IC50 level, which is not the case for the 2 others. So this, in theory, would give an advantage to zanubrutinib. Again, this is theory. We need to look at the studies to see if that translates also. Now, about the dosing. So as I said, it was different. So not the same dose for the indications for ibrutinib. So you have to be, you have to know about that and choose the right one. Acalabrutinib is twice daily because of the half-life that's quite low. And zanubrutinib, it's between the 2. So the 2 dosage are available, and there were studies that were done with that. And the dose that was chosen for the studies were 160 twice daily. But the 2 were good, and there weren't any difference in the phase 1. It was thought that 160 BID would have a better chance to prove superiority, and that's why it was chosen, but both worked really well. Adverse events were in line either when we were using the bigger dose once daily or separating twice daily. And for efficacy, so it's a complicated slide and you can look at it more closely after that, but you can see that there isn't much difference in the efficacy as to pertain to overall response rates and about the CR rates if you have the 160 BID or the 320 once daily. So both can be used. And we know that giving it once daily instead of twice daily, you do have better adherence. So not been shown directly on this, but we do have lots of data that shows when you have the choice between once and twice daily, giving it twice daily, you do lose some adherence to the schedule. So a bit about clinical studies, Waldenstrom's disease. So it's a disease that involves the IgM. It's a bit a bridge between non-Hodgkin lymphomas and multiple myeloma because it's the IgM that's involved. So it's a disease that is more for old people with an average between 65 and 70 years old, more common in men than women. Two mutations that are involved, the MYD88 and CXCR4 will affect the prognosis of the disease. And we do know that MYD88 wild type, which is not that common, but the response to ibrutinib is very low. So we'll talk more about that a little later. So most patients will be asymptomatic when we will diagnose the disease, but there are some symptoms that are associated, and they are hyperviscosity syndromes that might occur. Now, the first line of treatment is usually bendamustine and rituximab, and BTKi inhibitors are more used in second line or later. So here are the studies. There are less studies in acalabrutinib, which is why it's not approved in that indication. But we do have a couple, and the ASPEN study was a comparative trial between zanubrutinib and ibrutinib. So you do here have a idea of the response. So BTKis do work and do have good response rates, and certainly good PFS with 3 years, around 80% for the zanubrutinib trial. Now, the ASPEN, which was a head-to-head comparison, was really interesting. So there was two cohorts. One, we were testing the MYD88 mutations, but I said the MYD88 wild type did not respond well to ibrutinib. So there was an arm to see if zanubrutinib would work, but it wasn't compared because it would be non-ethical to give ibrutinib. Here are the results. So you can see over time, the best responses are on the bottom, and you can see that at each point, zanubrutinib did do better than ibrutinib. And even in the MYD88 arm, we did have good response rates, and which, as I said, ibrutinib does not do well for these patients. In terms of PFS, so there was a trend. Again, these are small trials. It's a disease that's more rare, so it's hard to have a big, robust number of patients. So this did translate to a PFS advantage, which was a trend to an advantage because of the low numbers, the difference was not statistically significant. On OS, well, again, we don't have a difference between the two groups for that. And now about the adverse events, well, BTKis, there was, so looking at adverse events, looking at trials head-to-head is the best way to look at them. As you can see here, there was more hematologic toxicity, more neutropenias, but that wasn't associated with infections. On the contrary, infections rate were higher for grade 3 or more event for ibrutinib. So that did not translate for the neutropenia. There was less atrial fibrillation, less hypertension, and less diarrhea in the zanubrutinib arm than the ibrutinib arm. So a summary of the data. Ibrutinib did improve overall response rate in PFS, but we know that zanubrutinib has improved tolerability compared to ibrutinib, and there was a trend to a better result, but it was non-statistically significant. So what about mantle cell lymphoma? So another not so often lymphoma, so less patients again with that. median age of diagnosis is 68 years old, more men also in that disease. So there are two different types. Usually it's the aggressive type that we see, but there is more of an indolent, that's about 20% of the cases, that can do a lot better and it's less aggressive, but the most common one is pretty aggressive. So we need to be aggressive with our treatment. So how does MCL present? Where there are a lot of symptoms, but nothing very specific. For the treatment, you need chemotherapy for these patients, and we're going to try to go for autologous stem cell transplantation because it's the best results that we have for this very aggressive presentation. So here are the pivotal studies that were done. So we don't have head-to-head comparisons for these also. So you can see the results that we have. So these are mostly second-line treatment because the first preferred treatment is going to chemo and stem cell. But we do have about 80% response rates and PFS of 20 to 30 months if I look at the zanubrutinib data. Now, so the summary for MCL. So the three drugs are active, but we don't have any comparison between. So more to come for this. There are many studies that are looking at it, but the three drugs can be used. Okay, so what about marginal zone lymphomas? Again, not a very frequent disease. So MZL is a median age at diagnosis of 67 years old. Again, more common in men than women. So their 5-year survival rates depend on if it's an extranodal disease or a nodal MZL. And the disease can transform to a more aggressive disease, diffuse large B-cell lymphoma in 7.5% of cases. About a third of the patients will have splenic MZL with no symptoms that can be monitored for watchful waiting. And the clinical presentation of extranodal MZL depends on the site which is involved. So stomach, which is often a site, will have more side effects related to that. Now, the treatment of MZL is very heterogeneous. You have a lot of options. So radiotherapy can be used, rituximab-based chemoimmunotherapy. And if it's a viral infection, also treatment for that can be used. Now, the gastric extranodal MZL can regress in 75% of the case by the eradication of a Helicobacter pylori. So that's a treatment that is usually given to those patients. Now, studies are, there are not many. So only ibrutinib and zanubrutinib has studied, only phase 2. And about the response rate, well, we get about 60% with the PFS. That we don't have a long follow-up for that, but it's BTKis can be used for that, but only the two ibrutinib and zanubrutinib. Acalabrutinib is not approved. We don't have any comparative data for that. Now, if we dive in the more common disease, so CLL is going to be the main indication for BTKis. We have a lot more patients diagnosed with that. So median age, again, at diagnosis is around 70 years old. Again, more males than females. Now, CLL, there are different types with asymptomatic patients that can be watched. So a lot of the patients we'll find on a lab work, and we're going to follow these patients. They don't need treatment right away for that. But for more aggressive or more late onset, we're going to need to give a therapy. Now, there are some mutations that are important, 17p, TP53, which are pretty much in the link, and 11q is another one. So you do have a few of them, and more aberrations that you have, the less of a good prognostic you will have. So that is important. Now, TP53 and IGHV are very useful in as a biomarker in CLL. So TP53 or 17p, patients do less well on that, and particularly for chemoimmunotherapy. And again, IGHV, unmutated or mutated, are quite different. So the mutated patients do more well and are responsive to chemoimmunotherapy, but not unmuted patients. The backbone used to be chemoimmunotherapy for CLL. So we had BR and FCR. FCR was for younger patients. It's really hard to tolerate it, but it is a fixed duration, and we did have high efficacy, and there was a potential cure. We see long-term patients that had a plateau, but a lot of them cannot receive FCR, and BR would be for that less side effects than FCR, but a little less efficacious. Now, what about BTKi inhibitors and BCL2 inhibitors? So they're getting more use now. And one of the problems for BTKis are the continuous therapy. So that's a bit of a problem, and greater cardiac toxicity risk, partly for ibrutinib. For BCL2 inhibitors, well, it's not a truly oral treatment because it's combined usually with obinutuzumab or rituximab. So you do have an IV component. The initiation or the ramp up dosing and TLS monitoring is quite a hassle to look at. And it's going to be a problem for patients that are have a renal insufficiency. Now, what are the first lines of treatment in CLL in Canada? So 17p patients are giving BTKis. About all of the patients we know is less used, but it could be used, but the preferred regimen would be BTKis. For younger fit patients, well, if you're going to give chemoimmuno, it's going to be FCR, but we are using a lot less. So the real choice is between BTKis and Veno. And for older patients, well, VR would be a choice, but we're using a lot more of BTKis or Veno for these patients. Now, second line or older, it depends on the first line of therapy that you will have. So depending on what the patient was given, you're probably going to switch to have a different mechanism of action. If you do have an intolerance to a BTKi, you can switch to another, but not if it's a failure. Now, what are the pivotal studies for the BTKis in CLL? Well, we do have a lot of them. 2 that are head-to-head that we'll dive more into. So you can see, we do see lots of good numbers for the PFS and overall survival for all of these trials. So this is quite well. If we look at the head-to-head, so acalabrutinib, 100 milligrams twice daily against ibrutinib 420 once daily for a relapsed refractory CLL. that doesn't matter that it was only in relapse. If you're going to use a BTKi, the difference between Acala or ibrutinib is the part that we are more interested in. So the study did show that it was a non-inferior study, and they both came out at a median PFS of 38.4 months. So hazard ratio of 1. So there is no difference in efficacy between the two, and none for overall survival also. The zanubrutinib trial, the Alpine study that showed zanubrutinib 160 twice daily compared to ibrutinib 420 once daily. So again, this was a relapse refractory study, but again, if you're going to use one, what's the difference between the two? And for the overall response rate, there was a difference. So zanubrutinib was better with 86 instead of 75%. And it did translate into an advantage in PFS. So 79% PFS at 2 years instead of 67. It was statistically significant. And it's also true, and even more true, for 17P patients or TP53 mutations. So the difference was larger in this subset. So for side effects, there was a difference in AF, so atrial fibrillation was, if you look at the acalabrutinib, it was less for the all grade events, but was not for grade 3 or higher, and was not for all cardiac toxicity, which is not aligned, which shows a little problems, but there was less AF. There were less hypertensive events, were less diarrhea of grade 3 or more, but there was more headaches. And acalabrutinib does penetrate more the blood-brain barrier. So this is an explanation for the headaches. In the Alpine studies, also less AFib, but for all of them. So, and less cardiac toxicities for all of them also. But there wasn't, we don't see the difference that we saw in the other study for hypertensive events and diarrhea. They were more aligned in this trial. So the two trials did show more cardiac events and problems with the ibrutinib than either Acala or zanubrutinib arm. What about administration considerations? So these drugs do go through the 3A pathway, and so there are lots of drugs to look at. Here we have from the monographs of the different drugs, what are the proposed considerations that we do need if we do have inhibitors, strong or moderate, or if we have inducers. Now, strong inducers should be avoided if possible. That is the major problem that we do have, because studies have shown that the PFS goes down if you do have an inducer with these drugs. For inhibitors, there are management solutions, so you can reduce the dosage with this. But it's less scary because there was no dose-limiting toxicities in the phase 1 studies for all of these drugs. Now, there are some things that you need with the drug-food interactions because of the 3A4 pathway. And for one of the drug, which is acalabrutinib, there is a problem with either PPIs or anything that reduces the acidity because of the formulation. Now there's a new formulation that's coming out, but it's not available right now. So if you're going to give a tablet, it's a problem with proton pump inhibitors. Now, renal impairment, there are no dosage adjustments. For hepatic impairment, it depends. So for each of these drugs, ibrutinib, you can consider dose reduction for mild, but you should avoid for moderate and severe impairment. Acalabrutinib, there's no dose adjustments for mild to moderate, but you should avoid for severe. And for zanubrutinib, there are no dose adjustment for mild or moderate, but there is a dose reduction for severe impairment, which is the only one that can be used for these patients. These drugs do have some side effects with other pathways. So you do need to look at the whole profile of your patient to see if there are other things to consider, but it's more of a problem for ibrutinib and acala than zanubrutinib. Now, about the adherence, there were some studies that showed that adherence was very important and that if you were missing some doses, the PFS could go down. So we do have one study here on the bottom that showed if you were less than 85% adherent in the first 6 months, which is quite high, there were more events for these patients. It was statistically significant. There is another study in the UK that had 3 groups, one that was split in 2. So group A was, in the first year, there was no dose reductions or breaks longer than 14 days. On group B, there was dose reduction, but no breaks longer than 14 days. And group C, there were breaks more than 14 days. And there was the other subset C2, which were half a treatment. So you can see on the bottom, the overall survival. There's not much difference if you dose reduce, but if you go more than 14 days without treatment, that's where you see a drop. And you can appreciate it more in the graph version, where you can see there's a great difference if you do a break more than the 14 days. So if you do a break, you should try to bring it back as quickly as possible. Now, the management of side effects. So there are common toxicities and other additional important toxicities that are associated with the BTKis. Now, here is a timeline. They don't all appear at the same time. Some of them can, but here's a timeline to see when you should expect some of these side effects. Now, we do have different incidences, and we're going to go through a few of these side effects. So diarrhea, which tends to be a bit higher in the ibrutinib than the others. It's generally mild, so grade 1 or 2, and usually it can be resolved without dose modification, especially in the first few months. So you try to keep the patient on the same dose and on treatment, and it's going to usually subside. So there are some management that if they are greater than grade 1 or 2, which usually, as I said, do not need dose modifications. Grade 3, you should try to pause and resume as soon as it's possible. So as soon as you get to grade 2 event, and you should reinitiate at the same dose. If it reoccurs, then you should try a reduced dosage for that. And there are therapies. Loperamide is the first choice, of course, for this. Now, if it's severe, you should also evaluate if it might be a C. difficile. Patients can develop that. But again, we're going to try to keep the patient on treatment and suggest a broad diet, small frequent meals, increase fluid intake to be sure not to dehydrate. Now for fatigue, fatigue is a bit tricky. It's most frequent in the first year. Now, it's also associated with the disease. So it's not sure if it's, you're going to get that from the disease or the treatment. But if we don't take care of fatigue, it can bring other problems, and it can bring on decreased motivation. It can bring on sleep disturbances, and patient can be quite frustrated if the fatigue is not taken care of. Now, again, usually this can be done without changing the dose, but the main therapy that I suggest for any patient that has fatigue is the physical activity. It's been shown in multiple cancers or treatment. That's the biggest thing that can help a patient. So it's something that's hard to manage, but you have to stress the importance for those patients. Now, what about headache? As I said, headache, acalabrutinib has a higher percentage than the other drugs. It's mostly in the first 3 months, and it subsides after that. So usually it's quite near the time of the pill that's taken. And only if in severe cases, you should be worried about bleeding, because major bleeding can occur in the CNS, and we would have problems with that, especially if the patient falls or something like that. Now, what can be taken for that? Acetaminophen, of course, and caffeine has been shown to be helpful for this. Again, we're going to avoid ibuprofen or other things that will interfere with platelets. But so usually first few months, and it's going to go away. You don't usually need to dose modify. What about arthralgia? So they can be arthralgia, myalgia, and muscle spasms. So acalabrutinib is associated with lower incidence of arthralgia than the two others, but muscle spasms are more frequent in ibrutinib than acalabrutinib or zanubrutinib. Now, again, this is a case that mostly resolves within a few months without those modifications. For only severe case, should you dose delay as small as possible if you can. So acetaminophen, again, can be taken for that. Ibuprofen will be avoided because of the problems with platelets. Stretching and straightening, hot and cold, can be used. If it's spasms, you can always check electrolyte, because that might be another reason. For the rashes, so IS prevalence is in the first year. Usually it's really mild, it's small things. You should pause if it's a grade 3 or more, so 30% of the body. So usually it's quite less than that, but for severe cases, you should only also be more worried about Stevens-Johnson reaction. It was reported in a few cases, but if it's a severe reaction, you need to be worried about that. For the smaller ones, topical corticosteroids and antihistamines can be used and usually work very well for that. Nail effects, so there are problems with that, brittleness, splintering. So it's reported as up to 60% of patients. So it's a topic that you should go over with the patients. Now, some suggestions. So biotin supplementation can help, topical ointments, and hydrosoluble nail lacquer, which I'm not very good at. I'm not using it. The last one is not available for everybody, but it's been shown to be effective, but it's hard to get here in Canada. Now, there are other adverse events of interest that are less often, but are problematic. And atrial fibrillation is one. So what can we do about that? So we need to find those patients. So we can use the new technology that's available. So if the patient is wearing a iPhone watch that can detect atrial fibrillation, but most of our patients are older and not wearing iPhone watches. There are other tools like Cardia Mobile is something that can detect that, but we're going to do a EKG at first for the patients, and it should be repeated, especially if the patient has some comorbidities associated with cardiac problems. But the patient should be educated on the signs, because this might happen when he's not seeing us, and he should talk about us if any of those signs are there. Now, we did talk about the letter from Health Canada that was in August of 2022, reporting the fatal cardiac arrhythmias that were associated with ibrutinib. So most of these cases were associated with patients that had comorbidities. So you need to evaluate carefully these patients. What about hypertension? So you can have that all the time that you're on treatment, and this is continuous. So the patient, the real world data shows it's even higher. So 50% of acalabrutinib and almost 80% of ibrutinib were reporting hypertension or worsening of hypertension. So you need to watch for this. The patient should monitor his blood pressure more often, and he should do something if it's over 180. So he should seek immediate help. What about hemorrhage? So we were worried about that. And first, most of the bleeding events are quite minor, with only bruising or things like that the patient will have. So you need to warn the patient about that.